Welcome to the Osteoarthritis Action Alliance Lunch and Learn for November 2015. My name is Kirsten Ambrose, and I appreciate all of you taking time to join the webinar today. I'm pleased to introduce our presenter, Maura Iversen. Dr. Iversen is professor and chairperson in the Department of Physical Therapy, Movement, and Rehabilitation Science at Northeastern University Bouvé College of Health Sciences. Her research interests include evaluation of the efficacy and effectiveness of non-pharmacologic interventions for persons with arthritis, understanding behavioral and social factors influencing adherence to pharmacologic and non-pharmacologic interventions in rheumatic conditions, and application of medical simulation to team healthcare. Today, she will speak to us about techniques to enhance adherence to physical activity and exercise recommendations, from theory to practice. Welcome, Dr. Iversen.
Thank you, Kirsten. I have nothing to disclose related to this presentation. So today what I'd like to do is describe challenges that patients face when asked to change their behaviors. Specifically, what I'll do is review some of the behavioral interventions that are used to promote adherence to exercise and physical activity. I'll also address some common assumptions and misperceptions about behavior change and synthesize the evidence for behavioral strategies to promote adherence, in the hopes that we will be able to apply some of these strategies to clinical practice. The management of osteoarthritis has progressed tremendously over the last 2 decades. We now have strong evidence that walking, aquatic, and resistance exercises plus manual therapy are effective in managing the symptoms of osteoarthritis, including pain, stiffness, and swelling. Weight loss, self-management, and exercise are key components to managing osteoarthritis symptoms. Early evidence has shown that weight loss of approximately 10 pounds can reduce your risk of developing osteoarthritis by nearly 50%. The recent ACR guidelines of 2012 have identified the use of modalities such as medial wedges, subtalar lateral insoles for various knee positioning, as well as tape, tai chi, and psychosocial treatments are very important in ensuring that patients with osteoarthritis have the best functional outcomes. Guidelines for exercise have also been presented by a number of professional organizations, including EULAR, or the European League Against Rheumatism, the World Health Organization, the Scandinavian Rheumatology Society, and in each of these guidelines and recommendations, there has been an emphasis on self-management and exercise, although our understanding of the best dose-response of exercise is still unclear. Behavioral interventions are strategies used to encourage individuals to adopt healthier behaviors. They're based on psychological theories and are focused on patient-directed behavior change. Theories suggest that psychological predictors of behavior change include a strong self-efficacy, realistic expectations of outcome, and psychological well-being. It's clear from the evidence that individuals who may be distressed or anxious have limited energy for change due to this mental distress. And so it's important to think about these components when we're counseling a patient to engage in physical activity. As I mentioned, there are a number of behavior change models and theories, as well as interventions that are available to you. Due to the time limits of this talk, I will focus specifically on motivational interviewing as a strategy, which is based on the transtheoretical model and the social cognitive theory. So how can clinicians support behavior change? One of the key components we recognize is the need to develop a different type of attitude than what we might have learned in the academic setting. Our role is really to be a negotiator and facilitator rather than the repository of all information. It's important for us to help patients explore information, and by that I mean examining the risks of the behavior or examining the risks of not performing the behavior, and to look at the positive consequences of a new behavior rather than barriers to behavior. So we are able to provide patients with choices as to whether to change and how best they see themselves adopting this behavior change. Some of the known barriers to adherence cover both environmental, psychological, and demographic features. Studies definitely indicate that adherence is problematic, with between 50 and 80% of patients being non-adherent to their exercise regimen. Barriers of adherence that you may not be aware of include whether or not the patient perceives the provider to be supportive of exercise and physical activity. So it's not to say that the provider truly has a negative attitude, but that in the context of clinical discussions that may be very time limited due to the need to talk about medical management, if the provider does not make a positive statement about the benefits of physical activity, patients are less likely to adhere to physical therapy referrals or engage in that exercise behavior. Other barriers include access and money, or lack of social support. So if individuals perceive that those that they care about or interact with are not supportive of their engaging in exercise, they're less likely to do it. I've already mentioned the consequences of psychosocial well-being, but another element to think about is readiness to change that we'll talk about as I discuss the transtheoretical model, health beliefs, which are based on patients' past behaviors, and disease characteristics, such as chronicity of a disease. The stimulus response theory is based on classical and operant conditioning, and the focus within this is to look at what are the stimuluses, the responses, and the consequences of behavior. Oftentimes you can focus on how to modify the external environment so that the patient can have better support of their behavior, such as engaging in physical activity. Another key to this is to encourage the patient to remove triggers to inactivity and to promote positive cues to exercise. That may be even in the context of a reward system of some sort. The transtheoretical model is developed by Prochaska, postulates that there are a series of stages that an individual moves through in order to adopt behavior change. That can be from the pre-contemplative phase, where they're not even thinking about changing behavior, to the contemplative phase, where they are considering changing behavior but have not actually done anything in order to promote that behavior change. The determination phase, which is also called the preparation phase, that may be when your patient actually has gone to the trouble of buying exercise clothes but literally hasn't started to exercise. And then of course the action phase, when they're engaged in the activity that is desired. Somebody reaches the maintenance phase when their behavior is continued for more than 6 months, and there's some evidence that suggests that behaviors that are performed more than 25 to 30 times become now ingrained in a person's lifestyle. So that there's various evidence around that, but that can be some sort of benchmark that you can think about behavior change. But it either can be defined as time or defined as the number of times that an individual is engaged in it. So once it's integrated into the routine, they continue that behavior until they need to terminate. But in the context of moving from action to maintenance, it's pretty common that people relapse. And so thinking about your role in encouraging patients to get back into the positive behavior is really important. So why is the transtheoretical model helpful in a clinical context? If you recognize the stage of change that your patient is in, you can better develop messaging that's targeted to promote behavior change. So what are some of the key questions to consider when you're working with patients with knee osteoarthritis? One is, what is your role with patients who are at each stage of change? How do you move from a facilitator to a promoter to an individual that helps to engage the patients in routinization of their behavior? How do you move a patient from one stage to the next? And what concrete actions you can take at the various stages of change. So I'm going to talk about these as I move through the rest of the slides. But before I begin, there's this kind of general behavior change rule with respect to the transtheoretical model. And that general rule for the population of individuals is that about 80% of individuals are in the pre-contemplative and contemplative phase. And only about 20% of the individuals you may see in a clinical setting are really ready and prepared to engage in behavior change. However, there's a caveat to this. and that is that education can also influence where people are in their readiness for behavior change. So some literature shows that individuals that are college educated are more likely to be in that zone of 20% prepared and 80% contemplative and pre-contemplative. But those that have less than a high school education, there's a higher proportion that are pre-contemplative, so not considering a behavior change, and there are only 10% that are in the preparatory phase. So thinking about the demographics of your patients as you're working with them in the clinic can help inform how you interact with them. Many of you have likely learned the 5 A's of adherence conversations while you were in school, and that is to address, assess, advise, assist, and arrange follow-up. And as we know, following up once is never enough, so you need to arrange for some sort of monitoring and structures for reinforcement in order to promote the behavior change. Kahn et al. In 2008 conducted a meta-analysis of patient education interventions, which were very heterogeneous. However, they were able to report moderate effect sizes, so effect sizes in the range of 0.45 to 5, for patient education programs. What they did find was that the most effective programs were programs that targeted only a single behavior, such as engaging in physical activity. Other more positive benefits were gleaned when behavioral interventions were used over cognitive strategies, and when patients were encouraged to use self-monitoring. So as I go through the behavior change theories that I'm going to talk about, I just thought maybe a case would be helpful so I can tie strategies into this particular individual. So Ted is a 45-year-old divorced construction worker with advanced knee osteoarthritis. It's not the first time he's ever been referred to physical therapy, but you learn he has never followed through on his exercises in the past. Looking through his medical record and speaking with him, you realize that he's 45 pounds overweight, he smokes more than a pack a day, and at the end of the day, his favorite behavior is to relax in front of the TV and drink a few beers. So in the back of your mind, I'd like you to think about, if you were Ted, what would you as a patient like to address first with your clinician in the healthcare setting? And I would also like you to think about, as a clinician, how would you approach the conversation with Ted, and what factors would you consider when trying to frame your conversation with him? So using the 5 A's framework, you would perhaps advise, so provide information and resources. But before you really do that, you need to really think about what stage of behavior change he is in, because otherwise he will not attend to the information that you're sharing with him. You also want to know what his beliefs are about exercise and his past experiences or supports for exercise in order to ensure that he's attuning to the information that you have to share. Next, you need to think about how you would negotiate a behavior change plan with him. So some typical questions that are useful in this case would be to ask him, what is he willing to change? What is he able to change now? Because you need something that's more immediate in order to ensure that he has successful outcomes and their realistic goals. And then to educate him about how to perform the exercise program, for example. But oftentimes as clinicians, we try to help patients identify barriers and develop strategies to overcome them without engaging the patient in this conversation. And so the other strategies that I'm going to talk about today, we'll talk about the benefits of having this be more of a patient-directed conversation. The other aspects of the 5 A's are to ensure that you give the patient your full attention and make sure that he or she is engaged in the conversation that you are having. And to think about what are the resources and their knowledge and history with respect to physical activity. So motivational interviewing encompasses all of these elements. Motivational interviewing, which was developed by Rolnick and Miller, is a directive patient-centered counseling style for enhancing intrinsic motivation to change by exploring and resolving ambivalence. It really truly builds on the transtheoretical stages of change model. The principles of motivational interviewing are to advise, to address barriers, have the patient identify choices, decrease resistance to their intervention, and for you to develop empathy, provide feedback, help patients set their goals. And you can accomplish this by a number of different strategies. One of the main strategies with motivational interviewing, because you're really trying to get the patient to lead the conversation, is to use open-ended questions and reflective listening strategies, where you affirm the positive comments that the patient may make, summarize it so you show the patient that you're truly listening to what they're saying in the clinical encounter, and you recognize and appreciate their perspective on their ability to engage in behavior change. And the key is to really, at the end, in the conversation, elicit self-motivating statements by the patient, such as, I believe I can, or I think I can, I will be able to, so that you know that you have some form of commitment that you can capitalize on as you set goals with the patient for their intervention. So your role with motivational interviewing is really that of a clinician who collaborates with the patient. So rather than leading the discussion, you would ask permission to discuss a particular problem or issue. So in this case, it would be how to get more physically active and engage in exercise program. And you really are to focus more on providing advice only when the patient is ready to receive it, which means you really do need to look at where they are in their stages of change and ascertain that and evaluate that before you move forward. It's also important, according to motivational interviewing, to develop empathy. And a way that you can do that is, in the course of a conversation, employ some reflective listening strategies, such as, I hear what you're saying, or, so in summary, you believe, and then continue the conversation with a summarization of the strategies and issues the patient has brought up. This way you kind of appreciate the ambivalence that the patient feels about engaging in behavior change, but you can also amplify their ambivalence and help them to develop future goals. I think a difficult component of this is really not to be the individual that's the vessel of all knowledge and begin to lecture the patient. And oftentimes that's very hard to do, although it sounds very easy to say. So the things that you could use as strategies to help you along this path would be to begin a conversation with, what concerns do you have about your knee osteoarthritis? Or if you were to start exercising, what would that be like for you? Or what worries you the most about your knee OA? Or what would be the worst thing that would happen if you didn't exercise? Listen to how the patient responds to those so that you get an assessment of where they are with respect to their confidence in their ability to engage in exercise, their perceived barriers, whether they're real or not, and how they may have been successful in the past to overcome these so that you can encourage those behaviors again in the future. So I mentioned self-efficacy once or twice now, and self-efficacy is one of the key components that we found is a factor for promoting behavior change, particularly as it relates to physical activity and exercise. And self-efficacy is actually both a component of motivational interviewing, but also the social cognitive theory that I'll talk about in a moment. So what actually is self-efficacy? Self-efficacy is the confidence somebody has in their ability to take action. So in order to ascertain that, it can be just a simple 1-minute question in the clinical encounter, where you ask the patient, on a scale of 0 to 10, where 10 is being the highest, how confident are you that you could adhere to an exercise program? You wait for the patient to respond, and let's say that Ted, our construction worker, says his answer is a 5. The next step would be then to explore why he's given himself that number. So you might start with, why have you given yourself a 5 and not a 1? And you'll be surprised at the type of information you can glean from this type of conversation. So in Ted's case, he may say something like, I'm very physically active at work, and while I'm physically active at work, I don't see the need to then try to perform planned exercises when I get home. Or he may say that in the past it made my knee uncomfortable, or I found it too challenging, or I was distracted by other things. And here's a chance for you to be able then to engage in a conversation about how to develop strategies to overcome these barriers. Another way that you could address it would be to follow up with a question like, what would need to happen for you to move from a 5 to a 7? So your role in supporting self-efficacy is to really show that the patient that you're confident in their ability to overcome the barriers that they perceive, and that the patients really must select and carry out the changes rather than you dictating what they should do. So here in your conversation, every time the patient brings up any sort of language that suggests that they are positive toward change, you really need to reinforce and support that with your commentary. So here, rather than reacting to resistance and arguing with the patient, perhaps in your mind you've recognized there's a great strategy that other patients you've worked with have used. Rather than suggesting that and saying, well, it's not really that difficult to exercise 3 times a week for 30 minutes, Mrs. Smith uses the following strategy. With that type of approach, the patient may tune you off right away, particularly if they're really in only the contemplative and pre-contemplative phase of change. So you really have to recognize that the patient is the primary source of both answers and solutions for their behavior change. Some patients, not all, do well with more of a cognitive approach to behavior change, and so you really need to look at the personality of the patient. But for those that benefit from more of a cognitive approach to behavior change, the simple decisional matrix is often quite useful. Basically what you do is to make up the chart and list the patient will list the benefits and costs of either not making any changes to their lifestyle. So for Ted, it would be a cost would be a risk of cardiovascular disease as well as progressive knee OA. And then what would be the positive changes in health that occur by engaging in the behavior? As a patient goes through this decisional balances and looks at maybe perhaps how the benefits outweigh the costs, it might trigger a cue to action for them to engage in behavior. The next theory that's been studied quite often in exercise adherence is the social cognitive theory. And the social cognitive theory by Bandura postulates that there's a dynamic interaction between personal factors, environmental influences, and behavior changes. So personal factors would be such things as goal setting, seeking social support, self-feedback, and reward. Behaviors would be whether or not the patients have the skills in order to perform the behavior and whether they have an opportunity to practice the behavior in order to become more proficient and master it. And then finally, the environmental issues or factors would be things such as social support and access for the behavior, so engaging in physical activity, what resources are available in the community to the patient, how maybe if they are the type of individual that enjoys exercising with others, who in their social circles would be available to exercise with them, and how can they learn from modeling of behavior. So oftentimes engaging them in community activities is useful for that modeling. So the key concepts in social cognitive theory are the positive attributes of observational learning. So in this picture here, I show a number of patients in one of the aquatic exercise programs for the Arthritis Foundation. And a patient who sees others enjoying it, being socially engaged, and seeing benefit from exercise may be more likely to engage then in that type of exercise program. Reinforcement is really key, whether the reinforcement is environmental or social cognitive reinforcement. And then self-control strategies such as monitoring, perhaps using a tracking device like a Fitbit or something that will track steps per day are really important, as well as stress management, because as I mentioned earlier, we recognize that individuals who are depressed, which is a fair proportion of those with arthritis, find it more exhausting to engage in behavior change. So if they can manage their stress, they may be more ready to adopt behavior change. And then finally, promoting self-efficacy through setting realistic goals. The worst thing that a patient can do is establish goals that are beyond their capacity, because it's so highly discouraging and damaging to their self-efficacy. The other is promoting problem solving and developing a set of intrinsic rewards. So what are the do's and don'ts to promoting behavior change and exercise? And this is just a short list, but do please think about targeting one behavior change or activity at a time. The literature shows that individuals who try to engage in more than one behavior change, i.e. for Ted, diet is important, as we know, because he's overweight, reduce alcohol consumption, and physical activity would be 3 different behaviors that would be probably overwhelming for him, who's likely an individual that's really in the pre-contemplative phase. So focus on one activity at a time so that the patient can demonstrate success and build their self-efficacy before moving on to other behaviors. Help the patients incorporate strategies for self-monitoring. So in your conversation with Ted, you may learn that he really enjoyed competitive sports as a young man, and so setting up some sort of internal reward system by tracking his steps per day might be something that's motivating for him, and you'll learn that through the types of counseling identification questions that you're asking in your interview. Be sure to assess your patient's self-efficacy with that simple 1-minute question. Ask the patients what's worked for them best in the past when they were physically active, and help them use that information to design a successful program. Try not to assume that all patients with our OA are equally affected by the same strategy. There's no one-size-fits-all. Some patients are really cognitively focused, so the decisional balance may be of benefit to them. Other patients may really enjoy self-motivating and exercising independently and not care whether somebody is exercising with them. So social exercise programs may not be the best for them, but helping them establish or locate a gym that has tracking devices that they can use with each of their weight machines might be a better strategy for that patient. Don't forget to reinforce patients' positive comments about their past successes with exercise, because most patients with NEOA oftentimes feel better when they move. So if you help them remember that once they're moving they feel better, they may be more likely to engage in the behavior. Don't forget to assess where they are along the behavior change spectrum to help target your messaging during the clinical encounter. Another strategy that's oftentimes helpful is just using a simple contract. So once they're in that preparation phase and getting ready to go, think about contracts as a way of ensuring that they are committing to their goals. And oftentimes this is useful only after they've talked about behavior change themselves. And then finally, texting and other types of mobile programming for tracking behavior change can be very useful to facilitate engagement in physical activity. There are a number of programs out there, actually many apps on physical activity that will send messaging to patients regarding reminders to engage in physical activity. Some are free and some are not. You can go to the CDC website and identify which types of apps are available and suggest that if a patient is really into technology. And many of these are based on theories of behavior change. And then finally, there are community resources for individuals with NEOA. So in the pictures I provided here on the screen, I'm actually showing two screenshots from your Exercise Solution Yes tool that was developed by the Arthritis Foundation. And the first tool, you merely log in, so this is just a face page with your name and email address. Once you click in, it asks the patient what areas of the body are affected with arthritis, what's their typical activity level, what types of exercises that they like, and then from that it will lead them onto a series of exercises, specific exercises they can engage in to help them with their patient-directed goals. Other programs that are available in the community that you may not be aware of are the Fit and Strong, the Walk with Ease, the Fitness and Exercise for People with Arthritis, and the Arthritis Foundation Aquatic Program. An even more comprehensive list of community resources for patients with arthritis can be found at the Centers for Disease Control at the cdc.gov website. And actually, there are some lovely programmings as well from the Arthritis Canada, which is the Arthritis Society of Canada's website. So in conclusion, positive self-efficacy for change is very important and can be easily ascertained in the clinic with a simple 1-minute question and 2 to 3 minutes of follow-up questions regarding a patient's confidence in their ability to exercise. It's really important to respond positively to comments made about even consideration of behavior change, and to ascertain patients' past experiences with exercise and what's worked well with them. Providing behavioral and environmental supports through access to community resources can be very helpful, or using reinforcement and rewards through self-monitoring and intrinsic forms of reinforcement are very important. But most importantly, please think about messaging in the clinical encounter. I recognize as a clinician that we have very brief time to spend with the patient, but even one few seconds of mentioning at the end of a clinical encounter when the patients are more likely to attend to what you're saying, to mention the importance of physical activity in any way, shape, or form, even simple walking, is very important, because patients will look to you as the expert healthcare provider and getting some sort of feedback about the importance of physical activity. Finally, begin and end every session with success, and allowing your patients and ensuring that they know that you value the outcome of a healthy lifestyle and know that you support whatever behavior change they select to engage in a healthy lifestyle is really important. So I want to thank you for your time today, and I'll be open for questions.
Thank you, Dr. Iversen. I think that was some great information. You know, it's always so difficult to adhere to an exercise program for anyone, healthy or otherwise. So, you know, when you add in chronic pain, that's just an additional challenge. I like the approach to consider stages of change and make sure that you understand where your patient is coming from. I think that's key to their success, as you pointed out. I also liked those community resources that you posted, a nice collection of things for individuals, whether it's an online tool or community-based programs that can be geared towards individuals or to groups, depending on what motivates your patient. So that's a nice collection that I would encourage everyone to check out. One very brief announcement. Next month, our December 16th webinar is with Dr. Jeffrey Katz from Orthopedic Surgery at Brigham and Women's Hospital. He's also a professor of epidemiology and environmental health at Harvard School of Public Health. So check out our website events page for more information and the title of his presentation. But for now, once again, thank you, Dr. Iversen. Very good information. I appreciate your time today.
Thank you very much, Kirsten.